morning. Today we will discuss a hot topic in clinical practice, which is a step from adequate to optimum hemodialysis. We will ask questions about the current adequacy of hemodialysis and what we should do more for our patients to have optimum hemodialysis. We all know that currently KT/V is the practical and the official, according to guidelines, reimbursements in different countries, toward adequacy parameters is to measure KT/V or the urea reduction ratio. Both of them belongs to very small solid, which is the urea. Current adequacy did not touch any of the middle molecules. Also, it didn't touch the ultrafiltration rate applied to patients. While you can reach an adequate hemodialysis and still the dialysis session time is short. Using bigger dialyzers, very fast blood flow, you can have adequate KT/V, but still you are far from optimum hemodialysis. So in this talk, we will focus on the negative aspect of KT/V and some points of improvement of hemodialysis therapy depending on our knowledge on the uremic toxins, the results of many studies on the mortality, health-related quality of life, and the outcome of our patients for the cardiovascular diseases. So before going to points of this talk, we can ask ourselves, are we doing adequate hemodialysis? Are we satisfied by these parameters of adequacy? Do you see your patient as healthy as in renal transplants or in the general population? By 3 times per week hemodialysis sessions, can the patient have a job in between? Post-dialysis fatigue is additional point to ask your patients, are you feel better after hemodialysis? And after how many hours you feel good? The agenda for this talk will be introduction to CKD, current adequacy in hemodialysis, steps for optimization, the quality incentive program, improving the hemodialysis membrane, identifying more uremic toxins with currently involved in the cardiovascular diseases, and role of inflammation. So before going to the talk, we have to define that what is adequate hemodialysis. Question to be addressed, you should ask yourself, what is the definition of adequate hemodialysis? And do you agree it is good to achieve a patient therapy or not? And if you believe in that, so identify your experience. And if you don't believe in that, please ask yourself why is still currently adequate hemodialysis parameters is on the guidelines. So before going to the adequacy parameters, a CKD is a non-ending journey. While going from stage 1 to stage 5 CKD hemodialysis, patient may go directly for hemodialysis as intensive patients, then awaiting for renal transplantation. Or patient of CKD may go to primitive transplantation, and if has no enough luck, he will return back to the journey of hemodialysis. So CKD is a non-ending journey, migrating from CKD 5 HED to transplantation or the reverse. The only curative way and preventive strategy is the optimum for dialysis patients. However, failure to find optimum therapy in hemodialysis opens the door for professional cheatings. The paramedical point in patients with CKD, a lot of paramedical medications and majority play on the feelings of patients to avoid dialysis, while it is a must in end-stage renal disease. The association of dialysis duration with outcome after transplantation in the Japanese cohort identify that primitive kidney transplantation could be beneficial for the death with functioning graft or graft loss or on patients post-transplant cardiovascular disease, meaning that hemodialysis current technique is considered a risk of inflammation and or immune modulation. While adequacy is achieved, still hemodialysis technique carry a risk of inflammation. The diagram of inadequacy of hemodialysis is multifactorial, and each step should be reviewed. We will focus on how is the failure of therapy is due to adequacy assessment or inpatient treatment. Now, what is optimal hemodialysis? Ask yourself what you feel that optimal hemodialysis should be. In two single words, optimal hemodialysis definition should improve the health-related quality of life, as in patients with renal transplantation at least, as well decrease the mortality rate. You need to move from a good structure of hemodialysis units to a process of hemodialysis with different hemodialysis techniques and safety measures. Then finally, what is the accurate measured outcome, not only for the mortality, but also for the comorbidity associated. The intensive hemodialysis can positively address a health-related quality of life comparing to renal transplant patients. Prolonged hemodialysis, as in nocturnal one, can improve the physical function, improving the patient well-being, improving the post-hemodialysis recovery time, how many hours the patients feel tired after each single hemodialysis session, and the overall score of comorbidity. So the health-related quality of life between nocturnal and prolonged hemodialysis and renal transplantation could be comparable. However, short sessions of hemodialysis is associated with negative outcome. So the agenda will go for the current adequacy in hemodialysis. The current adequacy is a standard KT over V. And while if you calculate that on basis of body surface area, you will find that women and the small patients weight are currently under dialyzed. However, still KT over V urea, an official marker of adequacy in between genders and in between big and small weighted patients. Also, KT over V did not describe the accumulation of microbiota-derived uremic toxins, the middle molecules, which is included in the vasculopathy and inhibitions of nitric oxides, thrombosis, and activation of platelets. So KT over V should be a mean, not a goal. It is not only the way to assess the adequacy of patients, it is just a starting point to assess your patient adequacy of hemodialysis. We call it adequate when the mortality rate of patients who are adequately treated is 25%, which is worse than most of cancers. So optimum hemodialysis is a moving target to improve the current mortality rate in patients on dialysis. Adequate hemodialysis, within 1 year, you will lose 20% at least from your patients. And by 5 years, almost 60% will die. Identifying patients more at risk with comorbidities will improve the survival. The KT over V, a magical formula for dialysis adequacy. On this clinical review, the results reveal that KT over V is not the best criterion and cannot be assured of dialysis adequacy based solely on that. So you need more markers besides the KT over V. KT over V did not apply to gender differences. And KT over V, K of what? Of urea, which is very small solids, and over the volume of the distribution, which varies between genders and weight of the patients. While T is the only small letter, still it is the important one. We have to stress on the time of the dialysis session, the length of the dialysis session. So it should be like that. Increasing the time is the most important one. Keep your patients on a long dialysis session is the most important one in adequacy of hemodialysis. Don't go for shorter dialysis session with very fast blood flow, bigger dialyzer, and you will find huge rebound after that. Only at least 4 hours is required per each dialysis session. In order to move from adequate to optimum hemodialysis, 14 points is required. You should have normalized blood pressure with minimal or no antihypertensive, normalized calcium phosphate product without phosphate binders, absence of intradialytic symptoms such as hypotension, cramps, and nausea, absence of interdialytic symptoms, patient can have a job and works fine, no interference with ability to hold the job, protein appetite is good, control of uremic toxins and the middle molecules, no dialysis related or access related hospitalization, neither alcotic nor acidotic, no evidence of left ventricular hypertrophy, no evidence of amyloidosis, long preservation of residual kidney function, life expectancy approximately that of living-related donor transplant, improves the survival of patients on hemodialysis, and systemic inflammation near normal. For the Japanese hemodialysis patients, a low KT over V was found in women and patients with a blood flow rate below 200 ml per minute and the treatment time below 4 hours per session. So in order to have an adequate hemodialysis per se, before going to an optimum one, the slower, the more gentle, the longer, and the more frequent dialysis treatment is the better. Urea and chronic kidney disease, the comeback of the century. So the kinetics of urea are not representative of the kinetics of several other uremic retention solids. And that all, urea cannot be held responsible for all complex metabolic and clinical changes responsible for the uremic syndrome. However, urea still remains valid. Why KT over V say nothing? Because KT over V of urea, it's an only small molecules, no middle molecules clearance, differ between females and males, and difference between small and bigger patients, no markers of protein energy wasting, did not describe different comorbidities, and adequate KT over V will have a low hemodialysis product. We will discuss what is hemodialysis product. So KT over V is typically the elephant in the room. We all know that it is not enough for assessing adequacy, but still remain valid. We know that this obvious problem or risk that no one wants to discuss, and why our survival rates are so poor when supposedly adequate dialysis is being achieved in terms of KT over V alone. Calling for new optimization of hemodialysis. If your patients ask you, can I do optimal hemodialysis, not just adequate? So you have to mention steps for optimum one, and you can calculate how many points you achieved for optimal hemodialysis and what is needed further. Game changers for the concept of dialysis adequacy. Not only for small water-soluble compounds, going to middle molecules, probably you can remove more protein-bound toxins, preservation of the kidney function, and dialysis with a membrane, larger pores, you can do hemodiafiltration, and improve the diet of your patients. According to the latest publication from the CDC dialysis safety approach, you need also to control infection, you have to do clinician education, you have to be adherent more or less to the guidelines, you have to talk to your patients and give him enough information and data reporting for analysis and the improving on the outcome. In the stage renal disease, the quality incentive program should be applied. The quality incentive program is to promote high quality service in outpatient dialysis facilities treating patients with end-stage renal disease. The quality incentive program has many scores. At least 10 points should be weighted: KT over V, vascular access type, bloodstream infection, standardized readmission ratio for patients, blood transfusions, hypercalcemia, how many patients in your unit has hypercalcemia, mineral-borne diseases, serum phosphorus and PTH, anemia management, how many patients reaching the target of hemoglobin, pain assessment, and the depression score. So the quality incentive program scoring is based on multiple factors put in one patient to assess his current disease condition and how much of care you are supporting your patients, not only from the adequacy point of view regarding the KT over V, but also the vascular access type and other parameters are important as the adequacy parameters. The end-stage renal disease quality incentive program rules needs continuous quality improvement effort. You have transparency and robust public reporting, identifying coverage and payment decisions, what is the incentives in hemodialysis payments, and what should be covered in these payment incentives. The Centers for Medicare and the Medicare Service Dialysis identifies the 5-star hospitals and centers by clinical measures, safety measures, and reporting measures with different weight. For example, you can have clinical measures in the 75%, safety measures for infection control and other 15%, and 10% for reporting. And this reporting is important for dialysis patients in order to have interpretation and to know the center what he achieved and what is the progress of improvement it is. So the total performance score depends on the clinical measures, safety measures, and the reporting measures. Example of the clinical measures like adequacy, vascular access type, hypercalcemia, safety dialysis events, bacteria in blood streams, and reporting of each single data on your patients. The payments 2018 reduction will apply to facility according to the following chart. How much achieved? Comparing a unit performance with other dialysis units. Improvement compares a unit performance to their previous year performance. And weighing 90% for the clinical and safety and 10% for the reporting. Without reporting, we will not find an interpretation of the current state of patient's modality of treatment and what is the outcome. So we can have here clinical performance, we are doing our best in clinical, but without reporting, there is no enough data for interpretations from different center and to study the comorbidities and what is the moving points for an optimal hemodialysis. The clinical measurements could be as reported like that. How many patients with arteriovenous fistula or catheters? How many patients have an adequate KT over V? How many patients has hypercalcemia? Who of them have bloodstream infection or recurrent hospitalizations or have any blood transfusions? So the overall is approached on the clinical background based on many of the clinical measures during hemodialysis. The structure of hemodialysis unit is important because at least 10 points should be fulfilled in each dialysis unit. You need administration room, educational room, waiting room, nutritional support, social support, technician and nursing rooms, meeting rooms to discuss each individual patient's at risk. we have also encouraging transplantations, clinics, and the PD training program. Or you may have to advise your patients for home hemodialysis. Home hemodialysis has been shown that it improves the survival with lower mortality risk, more convenient, more prolonged, controlling better the hypertension, left ventricular mass, and reported higher quality of life. And the overall outcome of patients did not stop on adequacy. You need more simultaneous evaluation of multiple risk factors for hemodialysis patients. The combined dialysis risk factors could be as low serum albumin for the nutritional, low body mass index, high C-reactive protein for infection, inflammations, as well other parameters of adequacy. So you can put your patients at risk. This could reduce the mortality in patients on conventional hemodialysis. So from adequacy to optimum hemodialysis, from payment per dialysis treatment, you may go to payment per treatment hour, encouraging centers to prolong the dialysis session time. Or you can calculate the hemodialysis product, which is how long the dialysis session in hours multiplied by the frequency of sessions per week. It basically does not depend on fake lab tests. Patient can monitor when he feels better. The best achieved hemodialysis product is 72. If you put your patients on 8 hours hemodialysis for 3 times per week, while conventional hemodialysis is 4 hours 3 times per week, the hemodialysis product will only be 36. If you're going to inadequate hemodialysis, more if you're going for still the same dialysis session, the same incentives, the same payment, but you're still going for the patient only 3 hours of hemodialysis, which is quite not enough for the majority of hemodialysis patients. Only the time factor is important, plus the frequency of hemodialysis. From the DOPPS study, many markers of survival have been identified, including the time. More prolonged time is associated with better survival. Serum phosphorus has U-shaped pattern. High serum phosphorus is associated with higher mortality, and as well lower serum phosphorus, because it defines the nutritional status of the patient. So it is a U-shaped. Optimal serum phosphorus is in the middle. Also, serum magnesium, which is rarely checked in our patients, has been shown that low serum magnesium is associated with several complications such as hypertension and vascular calcification, and also associated with increased risk for both cardiovascular disease and non-cardiovascular disease. So it is therefore advised to measure magnesium more frequently. Vascular access. Vascular access outcome reported in maintenance hemodialysis in a systemic review. Still, the evidence remains in support of autogenous access as the best approach when feasible. In the DOPPS study, in modern centers like in Japan, the majority having arteriovenous fistula. The caster rate had been decreased. However, in some other countries, the caster is still very high. And the better outcome for arteriovenous fistula. One additional point, where is the arteriovenous fistula? Is it proximal or distal? It's the best to have a distal arteriovenous fistula. While in countries increasing the proximal arteriovenous fistula raises the question of whether this practice shift may place patients at greater risk because exhausting available sites for future arteriovenous fistula creation. So better to start with the distal forearm arteriovenous fistula before jumping directly to a proximal one, and you exhaust all the native veins of the patients. Don't be aware and afraid from arteriovenous fistula increased cardiac risk. Sometimes nephrologists are afraid from doing arteriovenous fistula. In this review, a high output cardiac failure has been shown to be more common if the fistula flow greater than 2 liters per minute or in a patient with high output cardiac failure, meaning that the vascular access flow is 30% of the total cardiac output. The vascular access type differ in the elderly peoples. In one study shown that elderly people have more reported failure of the fistula and are more dependent on a central caster. Going to the graft has higher hospitalization or infection. So in the elderly people, the access type, if started with a native arteriovenous fistula, the possibility to move to caster is high and are more longer central venous caster dependent. But we have to start with arteriovenous fistula if available, and if you have venous mapping of the patient's veins suitable to do arteriovenous fistula. So in conclusion, for the elderly patient who underwent arteriovenous fistula placement had longer catheter dependency but a lower likelihood of death than those who underwent an arteriovenous graft replacement. So the second choice for elderly is doing native arteriovenous fistula and put a catheter if it's necessary to do. A well-functioning arteriovenous fistula as a start of hemodialysis journey in patients starting the hemodialysis session has the lowest burden, whereas a failed arteriovenous fistula or central venous caster access is associated with the highest burden.